why a counsellor is well placed to recognise that a client might be autistic, and what to do if you suspect that one of your clients is autistic. These thoughts began as a letter in response to an article in the BACP Healthcare Journal with which I and my fellow autistic therapists disagreed profoundly. The central thesis was that a therapist who suspects their client might be autistic should not say so, but should refer them to a GP as better placed than a therapist to recognise whether or not a person is autistic. The author drew attention to other conditions which may be mistaken for autism, or at least muddy the waters, described autism in outdated stereotypical terms, warned against the dangers of offering a diagnosis to a person who may be disinclined to question the word of a professional, and reminded counsellors that we are therapists and not clinicians. One definition of a clinician is a physician or other qualified person who is involved in the treatment and observation of living patients, as distinguished from one engaged in research. By that definition, I am indeed a clinician, not that it is a word I would ever use. And indeed, in that definition is a clue: the treatment and observation of living patients. Who observes a patient or a client more closely, with more attention, and in more detail than a counsellor? While I am certainly not a diagnostician, I am here to facilitate my clients' self-discovery, as Rogers put it, to be that self which they truly are, and autism is a fundamental a part of a person's self. In the time since autism has been recognised as a distinct syndrome, its definition has undergone a radical shift and expansion. For example, in 1985, Simon Baron-Cohen wrote, "Childhood autism is a severe developmental disorder. It is a rare condition affecting about 4 in every 10,000 children. The majority of autistic children are mentally retarded." We would now say that autism is a not very rare developmental disorder or difference. It is much more common than Baron-Cohen thought. The latest estimate is about 2 in 100. We also know that the majority of autistic people do not have an intellectual disability. There are also two very distinct ways of looking at autism. This split roughly equates to the two different ways of regarding disability: the medical model and the social model. In the case of autism, the split also roughly equates to the deficiency model versus the difference model, the latter more generally known as the neurodiversity model. The medical deficiency model may be expressed thus. Autism spectrum disorder, ASD, is an early onset neurodevelopmental condition that is associated with diverse social, occupational, and educational challenges. ASD is characterized by impairment in qualitative social communication and interaction, alongside rigid, repetitive, routine, ritualistic behaviors and adverse sensory responses to certain stimuli. The other model is quite different and comes from the experience of autistic people. There is no substitute for being autistic in understanding what autism is, and no excuse for being unaware of the many autistic researchers and educators who have contributed to the proper understanding of autism in recent years. To name just a few: Damien Milton, Dinah and Fergus Murray, Dora Raymaker, Kieran Rose, Chloe Farraher, Chris Bonello, Harry Thompson, Sarah and Jess Hendricks, Jack Den Hoyting, Monique Botha, M. Remy Yergot. And then there are the ordinary autists like me. I have lived experience of autism, as no non-autistic person has, whether or not they have lived with, worked with, or even been the parent of an autistic person. An enlightening parallel might be that even if I am married to a Swedish person, I'm not, by the way, have a half Swedish child, and know quite a lot about Swedish culture, I still do not have personal experience of being Swedish, growing up Swedish. But nobody will know that just by looking at me. And when I reveal my Scottish identity in passable Swedish, they will not say, "But you don't look Scottish." They will take my word for it, and maybe make some allowances. Speak a bit more slowly, not offer me surströmming. Autism is a way of being, a way of experiencing the world. It is not in itself a disorder, simply a difference. Many autistic people, myself included, regard it as not unlike a culture. We have trouble understanding the non-autistic world because it is not our culture, just as I, as a Scot, might have trouble understanding the culture of Sweden. And non-autistic people have equal trouble understanding our culture. This has been demonstrated very nicely by Crompton et al., is that the heart of Damien Milton's double empathy theory and underpins Luke Bearden's use of PNT, predominant neurotype, to describe non-autistic people. The autistic neurotype is not inferior, it is simply not predominant. In an inclusive world, autistic people and non-autistic people would be seen as people with two different operating systems. Some people prefer Apple and some people prefer Microsoft. Undoubtedly, each operating system has its advantages and disadvantages, but both are equally used and accepted. If you gave me a laptop and asked me whether it was a Mac or a Windows PC, I would know immediately. I am trained on both and can use either equally well. I have a preference for Mac because that is what I am most accustomed to. But I can do almost everything on a PC that I can do on a Mac, just slightly differently. Autism is not a collection of impairments, challenges, adverse reactions, bizarre behaviors. It is a combination of experiences, a way of experiencing and processing the world. It is striking that when autistic people talk about autism, it is the experience that we focus upon, while when non-autistic people do so, it is the behaviors and impairments. The relevance of all this to a counsellor who is wondering how to proceed with a client whom they suspect to be autistic should be obvious. Are they thinking, this client has a severe developmental disorder typified by challenges, impairments, deficiencies, strange behaviours, which is incurable and which means they will never be able to live a normal life? If they discover this, all their hopes will be dashed. Or are they thinking, this client has a cognitive and sensory processing style which is not the predominant one. It would be very useful for them to know this, so that they can live their best life and play to their strengths. If their train of thought is the first, then I understand why the counsellor might send the client to the GP. If I, as a counsellor, am faced with a client who appears to have a medical issue, I will say it might be worth going to the GP with that. If a client appears to be suffering from a mental illness which cannot be explained by the circumstances of their life, past or present, and is an obstacle to psychological contact, then I may well say the same. If I regarded autism as a medical issue or a mental illness or disorder, it is still classified as a mental disorder in the DSM, as indeed homosexuality was until less than 50 years ago, then that would be how I would proceed. So it is understandable that a counsellor who regards autism according to the medical model would send the client straight to the GP. However, if your thinking is more along the lines of the second option, you will proceed differently. If one wants a diagnosis of autism, one has to go through a diagnostic process. But while diagnosis can be very valuable and is not within our remit as counsellors, self-knowledge, self-understanding, and knowing what to do with our new identity as autistic are at least as valuable. And that most certainly is within the remit of the counsellor. And that process begins in the counselling room and begins long before the word autism ever appears. So, when you are talking with a client and you think, I wonder whether they are autistic, do not primarily observe behaviors or mentally tick off impairments. Ask about experiences. If you really know about autism from the inside, either by your own lived experience or by listening to autistic people, you will have progressed beyond stereotypes and the DSM and know the right questions to ask. Autistic people vary as much as non-autistic people do. I belong to an international group of autistic therapists, and our backgrounds and our current environments, our special interests and our approaches to clients could not be more different. We have psychologists and art therapists, CBT therapists and person-centered therapists, and human givens and transactional analysis and music therapists. We have integrative and eclectic and single modality therapists. One of us calls her practice Curiosity Spot, because you never know what you'll find. You cannot identify an autistic person by the type of childhood they have had, the type of relationship they are in, the type of work they do, the things they are interested in, whether or not they have friends, whether or not they are creative, whether or not they look autistic. You can only identify an autistic person by their experience of the world. Ultimately, it is indeed not for you to say that a person is autistic. It is not for the GP, not even for the psychologists, the speech and language therapists. It can only be a joint venture and centered always on the experience of the person. But maybe it is for you, as the one who is most closely attending to them, to start the conversation. So, what are the clues that might alert you to the possibility that a client might be autistic? Do not ask whether they are fascinated by dates, or whether they would rather go to a museum or a theatre. Do not ask whether they would rather go to a library than a party. Do not ask whether they are more attached to things than to people. In other words, don't start with the autistic quotient AQ test. Many of the questions are based on stereotypes. Some of them are really opaque to an autistic mind, and some are so ambiguous that they are hardly worth asking. It is not a bad tool to give an indication of whether it is worth referring to diagnosis, and it or its shorter cousin is what a GP will probably use. But you, as an attentive counsellor, have already bypassed the symptoms and are getting the feel of the person and their experience of the world. You will maybe have spotted that although your client is presenting with depression, anxiety, trauma, whatever, there is something else, a difference. Don't make an effort to identify it. In focusing therapy, we sometimes say, there is a something, and allow it to become clear in its own time. You might hear them talk about sensory sensitivity. Sounds, smells, scratchy clothes, bright lights, or sensory seeking, soft fabrics, weighted blankets, cold water, or a consistent feeling of difference going back to childhood. They may comment on their slow processing speed, despite the fact that they have average or high intelligence, or refer to perceiving the world as bewildering, or to consistent misunderstandings going both ways. One autobiography is entitled, "But you said..." They may well comment that they are aware that being themselves is often disastrous, and that they feel that they are constantly masking, camouflaging, imitating others in order to look or behave right. They may note a tendency to see details rather than the whole, and almost certainly an intense focus on special interests. These can be anything from the stereotypical computer programming or train timetables to language, traditional music, or circus skills. Many autistic people get into trouble at school or at work due to what is known as the autistic spiky profile, skills levels varying dramatically from one area to the other. The rare savant is an extreme version of this. Samantha Kraft has put together a very good unofficial list of autistic traits. Just to be clear, I am not advocating saying to your client, I think you are autistic, or even had it occurred to you that you might be autistic. As a person-centered therapist, I would almost never derail a client like that. There are, of course, times when you realize that they have said everything except the word, and they are wordlessly begging you to say it. Then, cautiously, tentatively, maybe. I am in an unusual and privileged situation as one of the few fully out autistic therapists in the UK, and a client choosing to come to my practice generally knows that. My client base at the moment is about 80% autistic, 20% non-autistic. So if I were to encounter a client describing their experiences in ways that corresponded with the autistic experience, it would not be unreasonable for me to ask them whether that was why they had chosen me as their counsellor. A non-autistic counsellor might, for example, say, there's something else, isn't there? Something that goes back beyond the depression, the anxiety even, the trauma. Or you might pick up the client's language of difference. It's not easy feeling different, is it? Or to a client who said they feel alien, tell me what your planet looks like, all depending on what feels right for that client at that time. There can be no hard and fast rules beyond the core conditions of empathy, congruence, and unconditional positive regard. Except, of course, first, do no harm. And if you are working with an autistic client, diagnosed, self-diagnosed, or questioning, and you see autism according to the medical deficiency model, you are likely to do quite a lot of harm. Autism is not a deficiency. Far less is it a tragedy. For most of us, the knowledge that we were autistic came as a huge relief. I have quoted many times my own exclamation of, "So I'm not mad, bad, and dangerous to know, just wired differently." A straw poll among my peer group of autistic therapists revealed that of 50 respondents, 44 experienced their diagnosis or identification with joy or relief, and only 1 out of 50 felt that their diagnosis meant they would not be able to achieve what they wanted to in life. This pattern seems, anecdotally, to be replicated in most groups of late diagnosed autists. And yet the tragedy narrative persists. Presenting autism as a disorder, almost a disease, has a devastating effect on autistic people. Monique Botha speaks in detail of the dehumanization of autistic people in research, starting with her own experience during her undergraduate degree. She found her own identity relegated to abnormal psychology and described in stereotypical and inaccurate terms. She comments, "I became not just a triad of impairments, or somebody who lacked the ability to infer the minds of others or empathize, but something that was described in terms of categorical subhumanness, incapable of culture, friendship, community, and reciprocity. Someone who is less domesticated, more aggressive, an economic burden, with integrity equivalent to non-human animals alone. Though my cats might have something to say about that too." Some of the quotations that Botha gives in this article should come with a trigger warning, and I do mean that literally. This is sadly still an experience familiar to autistic people who attempt to counter the stereotypes in research and in the wider community. It should not be the experience anyone has in the counselling room, which should be the ideal place for a client to start on the journey to recognising their own possible neurodivergence. Referring a client directly to a GP without giving them the tools to describe their experiences and feel well grounded in their own self-understanding can be problematic. Elaine Nicholson rightly states that over half of adults who suspect ASD initially visit their GP, Yet ASD is frequently overlooked or misdiagnosed in adult patients by primary care physicians due to lack of experience in detecting autism traits. In addition, adults with ASD are at high risk of co-occurring mental health conditions, non-suicidal self-injury, and suicidality. This is absolutely true. GPs often enough have neither experience nor training in how autism presents in adults, and especially in women. These adult patients have by definition not presented in a typical way in earlier life, or they would already have been identified, and so are extremely likely to be missed by an inexperienced and busy GP, especially if they are apparently more pressing presenting issues. In a 2019 blog post, Autistic Science Person describes the long list of very common misdiagnoses that autistic people regularly receive before the correct diagnosis of autism is finally arrived at. No stigma should accompany a diagnosis of schizophrenia, BPD, bipolar disorder, depression, and the rest. The point is simply that a misdiagnosis means inappropriate treatment and sometimes actual medical harm. Then, supposing the GP did have sufficient knowledge to identify that my client might be autistic, will they do the AQ test, talk about disorder and deficiency, and refer without discussion? That could be devastating had the client not already explored autism as a simple difference in experiencing and processing style. Or will they avoid the question and simply reassure the client that it is probably simply depression or anxiety? It is surprisingly difficult to persuade a GP to refer an adult without major co-occurring conditions for an autism assessment. Again, that is understandable if one regards autism as something bad, a disastrous diagnosis on a par with an incurable disease. It is, of course, incurable, but that's because it's not a disease, but a minority sensory and cognitive processing system. I can't cure my blue eyes. I can mask them by wearing tinted contact lenses, but I can't change their actual colour. Why would I want to? And neither would I want to cure my autism, which is an essential part of who I am. It is my operating system, as Mac OS is the operating system of my laptop. Without it, I would not be myself. It would seem strange to me to refer a possibly autistic client to the GP without discussing it with them first. We are not diagnosing, we are listening and discussing. There is no danger that our client may be cowed by the opinion of an expert. In the counselling room, the client is the expert. We are not imposing our opinion, we are asking them what they make of their experiences. In addition, many autistic people, because we do not share the views and values of neurotypical society, often enough we're not even aware of them, and when we are, they seem random and strange, may actually be less likely to accept an opinion simply because it comes from someone who has a higher status in neurotypical society. We may actually be more likely to go away and do the research ourselves. It is true that some other conditions may muddy the waters when we are trying to identify whether or not a person is autistic. Both anxiety and depression are extremely common co-occurring conditions. Suicidality, self-harm, and eating disorders are also more common in autistic people than in the general population. It is worth commenting that autistic people are not necessarily, as such, more prone to these conditions. Consider how you might feel if you were living in a society which was not only incomprehensible and unpredictable, but actually designed to discriminate against you. Among people who constantly misunderstand you and tell you that you are at fault, that your very being is deficient and disordered, that you are doomed to a life of failure. Bullied, gaslighted, confused, in constant pain from sensory sensitivities. It is a wonder that any of us emerge unscathed. Some of us do. The concept of minority stress, which has been predominantly used to explain the health disparities within the LGBTQIA plus community, also applies to autistic people, as Monique Botha explains. She says, it posits that social disadvantage and marginalisation results in an increased burden, which in turn can result in mental and physical health disparities. The counsellor who's sat with the client and listened to them week in, week out is far better placed to disentangle the autism from the rest than a GP who is faced with the whole story in 10 minutes. So, when you begin to suspect that your client is autistic, don't think, oh no, should I break the bad news to them, and if so, how? Think, here is a chance for this person to discover something really essential about the self they truly are, to stop trying to be what they are not, and at last to play to their strengths. As Nick Walker says, ultimately, to describe autism as a disorder represents a value judgment rather than a scientific fact. And to quote one of my own autistic clients, with permission, harmony singing is a perfect analogy for the way we should view difference. We are not singing the same thing. Sometimes the parts are very different indeed, but all those different things make up something beautiful.